Before we begin, please pause and take our pre-training survey. If you are a health provider or other health staff, go ahead and take the one on the left, and if you are a health student, go ahead and take the one on the right. Links for both of these surveys will be included in the video description below as well.
Welcome to today's training on promoting health equity for individuals with intellectual and developmental disabilities. We're super glad to have you joining us. Just really quick introductions. My name is Samantha Vernon. I am a graduate intern from UNC doing a public health practicum with Envision. I've been lucky enough to partner with them on this project. And I'll go ahead and let my co-presenters introduce themselves.
Hi, my name's Candace Kramer. I'm the Fund Development and Communications Director here at Envision. I've been here about a year and a half, and I am really excited to share my passion with health equity and the people we support who have intellectual and developmental disabilities.
And my name is Celeste Ewart. I am the Executive Director for Envision, and I have been with Envision since 1992. So when we are recording this, it has been 31 years since I have been here. Thank you for joining us. All right, so a little bit about Envision. We are what's known as a community-centered board, and there are 20 across the state of Colorado. We were founded in 1965, and all 20 community center boards were founded around that same time as a way to provide services to people in the community. Prior to that time, services were only provided in institutions, and many families didn't want to put their son or daughter or a sibling into an institution, but they needed some support to keep them at home. And that's why we were established. We are funded through primarily Medicaid funding. About 85% of our $9 million budget is Medicaid funded through a contract with the state of Colorado Healthcare Policy and Financing. So we don't have a contract directly with federal Medicaid, just state. About 8% of our funding is also state general funded, and then about 7% of our funding comes through sponsors, donations, grants, those types of things to try and make us whole. We provide services to over 2,200 families or people with intellectual and developmental disabilities throughout all of Weld County. That's an unduplicated number throughout the entire year. We're what's known as a person-centered organization, and so we really consider what's important to and important for people. We don't believe that there's a one model fits all. We want to individualize services and really try to meet the needs of the people and families, because we know that every need is different. We have 3 oversight organizations that we work with. I already mentioned Healthcare Policy and Financing, or HCPF. We also work with the Colorado Department of Public Health and Environment. They do a lot of our monitoring, our audits, and reviews to make sure that we are in compliance with the Colorado rules and regulations. And then it says the Colorado Department of Human Services, but that changed recently. We used to report to them for our early intervention program, but very recently the Department of Early Childhood was formed at the state level, and now our early intervention program reports to that department. We provide services for people from birth until death. We have an early intervention program that provides services to children from birth to age 3. The requirements or eligibility for a child to receive early intervention are they must have a delay of 25% or more in 2 or more areas of development, or a 33% delay in 1 or more area. Some of those developmental domains are things like speech, occupational, social, emotional, physical, just to name a couple of those. The early intervention, that delay can actually go up to age 5, but we only serve until age 3, and then they transfer over to the Department of Education. In addition to those delay percentages, a child can have a known condition or an established condition. So they could have been born prematurely so many weeks, or a low birth weight, or the mother wasn't getting prenatal care that was needed, or we know that there was drug or alcohol abuse occurring during the pregnancy, that would automatically qualify someone. And then if a child under 3 has a parent who has a developmental disability, even if they are not exhibiting any of those delays, they would automatically qualify to receive services. We provide case management for 4 Medicaid waiver programs, 2 children and 2 adults, the Children Extensive Support Services, Children's Habilitative Residential Program, and then the 2 adult programs are the Developmental Disability Waiver and the Medicaid Supported Living Services. And we serve about 600 people in those 4 programs. We also have state general fund programs, the Family Support Program, and then State Supported Living Services and OBRA. And we provide case management to about 250 people in those case management programs. In addition to case management, we also provide direct services. We have our program services direct service arm of Envision, where we provide residential services through what are called personal care alternatives, where basically it's just support. We hire direct care staff to go in and help people with as much as 24-hour supervision if they need that. We do family caregiver model, and we do host home provider model. We also provide adult day program services through supported community connections and specialized habilitative services. And we provide individual supported employment, where we get competitive integrated employment for people out in the community. We support them with job discovery, job development, job placement, and ongoing job coaching. What many people don't realize is that in addition to providing our own direct services, Envision works with over 150 other programmed approved service agencies, or PASAs, you might hear that term, throughout Weld County. And so we do the 850 families in case management, but we also work with over 150 other programmed approved service agencies. So what we hope that you will gain from this training today is to expand your knowledge about intellectual and developmental disabilities, what it is, who qualifies, how to identify someone. We will explore the history, disparities, and unconscious bias that impact care for people with IDD. We hope to enhance your communication skills and adaptability to improve care that you are providing to people, and prepare to apply training and seek additional learning if you would like to have more information about that. So a little bit more about IDD. We would like to start by reviewing what the criteria is for somebody to be diagnosed with an intellectual or developmental disability. You heard us say IDD, so we'll probably be using that through most of this presentation. A person with IDD must have an IQ of 70 or below. This chart kind of gives you an idea of what the different levels of that look like. So the mild is somebody with an IQ of between 50 and 70, moderate 35 to 50, severe 20 to 35, and profound would be below 20. The margin, 90% margin of error, basically means that we can support people whose IQ might be a little bit above that 70, but they might have other disabilities that affect things like daily living skills. They might need help with nutrition planning or meal preparation, taking medications. They might have a physical disability that requires additional help with personal care, transportation. So if they have multiple things, then their IQ can be a little bit higher than 70, and they could still be eligible for our services. The disability must limit their adaptive behavior. So it truly is cognitive. It can affect communication, receptive and expressive language, a lower understanding of time or money management, maybe reduced skills through social interactions, and practical skills related to their daily living. One thing that most people don't realize is that for them to be eligible, the disability had to have occurred prior to age 22. If it happened after that age, say a car accident a little bit later in life, and it affected these things, they wouldn't qualify for our services. The primary reason for that is it's determined that if it's after age 22, that they've already developed, and so that it wouldn't be considered a developmental disability. There is some discussion and thought that that age could change in the future, because a lot of research shows that much of the brain development is still occurring up to ages 25 or even 26. But at this point, it's been 22 for many, many years, and it still is now. Okay. There is no one way to know if a person has a developmental disability, but there are some traits and characteristics that you can look for to see to try and help you determine if somebody might have a disability, developmental disability. So some of those things could be physical appearance. And some of these that I'm going to address do occur in people with developmental disability, but it's also important to know that there are some people who may have these, with the exception of Down syndrome. They may have the cerebral palsy, epilepsy, or autism, and not necessarily have a full developmental disability, because people without a developmental disability can also exhibit these things. But somebody with cerebral palsy may have an unsteady gait, slurred words. Just visually looking at them, they may appear as if they are intoxicated. So it's, you wouldn't want to make an assumption about someone because they are behaving this way. For epilepsy, we do serve many people that are diagnosed with epilepsy, either during their seizure or even following a seizure. They may appear as if they are under the influence of drugs or withdrawing from drugs. They could appear very confused, not sure of what just happened. For people with autism, they could be engaging in self-injurious behaviors, maybe hitting themselves, pacing, rocking if they're in a chair, and they're doing this as a coping technique. Many people with autism have a difficult time with stimulus, if it's loud, if there's a lot of people around, if they're out of their normal routine, and these things may be ways for them to more easily cope with what is going on around them. One thing to note, we receive a lot of referrals for people with autism, and although we serve many people who have a diagnosis of autism, there are a lot of people diagnosed with autism whose IQ is just too high for them to qualify for our services. And when that happens, we do try and find other resources for them, like the Autism Society, maybe some other waiver program. But just because they have autism does not automatically qualify them for our services. And then somebody with Down syndrome that you would probably recognize their appearance. It's pretty distinctive. And one thing to keep in mind is that people with Down syndrome experience low muscle tone. That actually causes the look that you see in the face of somebody with Down syndrome. And this can affect their breathing, their speech. So, very important to keep those things in mind when supporting somebody with Down syndrome, and that those are the reasons why they have those speech and breathing difficulties as well. All right, and then some of the behavior traits to consider for people with intellectual and developmental disabilities. Many of the people we support have boundary issues. They don't understand what personal space is or what's too close to someone. So using concrete descriptions, if somebody is right there in your space and you don't need them to be there, rather than asking them to stand, can you please move further away from me or not be so close? It would be better for you to say, hey, would you mind sitting in that chair over there? Or can you wait in the other room? Something concrete would help them have a better understanding of those boundary issues. They may take, like if they're thirsty and you've got a drink on your desk or table, they might take that not to steal it, but because they're thirsty and there's something there to drink. So just keeping those kinds of things in mind. They can be easily influenced and eager to please, so they may say what they think you want to hear, because they do want to be liked, they want to be included, they want to be feel like they're being useful and being helpful. They may think that that's a way to make friends. So again, not intentionally trying to lie, but saying something that might not be true because they think it's what you want to hear. They could become easily frustrated, especially if they're trying to communicate something and you're having a hard time understanding them. And we'll get into some communication techniques here in a few slides, but they could become easily frustrated. They may ask if they are in trouble, even if they haven't done anything wrong, but just again, trying to do that people pleasing and asking if they are in trouble. They might not use words to communicate or may have unclear speech patterns. Again, we'll talk a little bit more about some things that you can do to try and help overcome if there's a speech impediment or even communications different than verbal, and how to work with that. And then if you suspect that somebody might have a developmental disability, but you're just unsure, there are a couple tasks that you can try. Again, keep in mind that this isn't true of everyone, but many people we support would have troubles doing at least one or a couple of these things listed here. So if you were to ask for their address or phone number, they might not be able to actually give it to you. They might be able to say, oh, I live by the Walmart, but maybe not even tell you the Walmart on 23rd Avenue or 10th Street. They just might know it's by the Walmart. They would have a challenging time giving you accurate directions. So they probably couldn't tell you how to get from Envision to their house. They couldn't say go east on 37th Street and north on 23rd Avenue. They couldn't do something like that. They might be able to say, go to the gas station and then you turn this way. But again, the street directions would be hard. Making change is difficult for a lot of the people we support. A lot of people will know how many quarters will buy them a pop because they can do that at work or at day program, but they might not be able to say, if you had a couple quarters and a dime and a nickel and a few pennies, they probably couldn't count and tell you how much change you actually had if you were to do something like that. Telling time, especially on a clock or a watch that has hands versus the numbers, people might be able to read the number to you, but they still might not really understand that it's 8:30 in the morning. What works better for them regarding telling time might be connected to more of an event. So they might be able to say, oh, it happened after day program, or it happened before Wheel of Fortune, or we had just finished dinner. So if you are needing to determine, help somebody understand time or chronology of something, using events instead of actual time might be better. And then finally, writing their name. A lot of the people we work with do not write in cursive. And so to do an actual signature is very rare for the people we support. If you were to ask them for a signature, you would most likely get like block letters printed out, name, as opposed to a signature that would be in cursive. So those are just a few things that you can look for or ask people to try and do to determine if they might have an IDD.
Okay, great. Thanks, Celeste. Now that we have a foundation, let's discuss how we can understand and enhance health equity when providing care. To understand the importance of approaching care with health equity, it's necessary to understand the history of how individuals with IDD have been treated. In the 19th century, advocates for individuals with IDD started institutions designed to teach life skills in preparation for integration into society. Unfortunately, due to issues such as overcrowding, lack of funding, and leadership support, these institutions became permanent living situations where individuals were often over-medicated and required to work to support the upkeep of the institution. You can see in the early 20th century, there was even a push to sterilize individuals with IDD as part of the eugenics movement. In the mid-20th century, as families and communities began advocating to transition care from institutions to home care, with community support services. This is when organizations like Envision were created. And in the last couple of decades, it has advanced even further into person-centered care models that highlight the strengths of individuals over their limitations. A lack of understanding has led to a number of incorrect assumptions about individuals with IDDs. So you can see here some of the common myths and stereotypes that we'd like to help address. One is that people with IDD are dangerous and should be avoided or ignored. Similarly, that they cannot be trusted or they're not credible, when in fact, individuals with IDD are actually more likely to be the target of violence, abuse, or extortion, which leads to a high percentage of diagnosis of PTSD. Another myth is that they don't have normal feelings or don't feel, when actually the truth is that people with disabilities live like everyone else. They go to school, get married, work, have families, they laugh, cry, get angry, even have prejudices or biases too. They plan, dream just like anyone else. Another myth or stereotype is that people with IDD are not capable of understanding things, as well as they can't or won't communicate. And although some people with IDD may require accommodations, like we'll talk about in a little bit, to facilitate communication and understanding, they're actually fully capable of engaging. And the last one that is a common myth or stereotype is that people with IDD always need help. And like Celeste talked about earlier, or 85% of people with IDD are actually in the mild diagnosis, the 50 to 70 range, and are capable of living independent lives where they actually are able to give help and not just receive it. So in addition to the social stigma and discrimination people with IDD can face, they experience a number of health disparities. And this is kind of the crux of where our this training comes from and is hoping to address. You can see on this chart that life expectancies for this population can range anywhere from 10 to 30 years below the general population. So someone in the more profound diagnosis criteria may live only into their 50s, where someone with a more mild diagnosis may live in their 70s compared to a general population life expectancy of the 80s. They experience a higher rate of morbidities and chronic and secondary conditions. And they're less likely to receive preventative screenings and more likely to be placed on end-of-life care earlier. And part of the lower rates of preventative screenings we can help address by doing things that we recommend in this training to ensure a better experience for people. One of the preventative screenings that people tend to not receive are like women with IDD are 72% less likely to be screened for cervical cancer. And so have conditions that ultimately could have been prevented but lower their life expectancy without the treatment or prevention early on. They're also at risk for diagnostic overshadowing, which is where new health issues are hidden or discounted by prior diagnosis or issues. And I'll read an example from a physician actually in Colorado Springs who shares an example of diagnostic diagnostic overshadowing. This doctor says, not long ago, a patient of mine with Down syndrome came to my office with staff from his group home to address sundowning. He had carried a diagnosis of Alzheimer's disease for a few years at the time, originally diagnosed by an outside provider. When his group home staff had complained to his psychiatrist that he was falling asleep at day program, typically in the later afternoon, this is where the term sundowning comes from, and he wasn't sleeping through the night, the psychiatrist attributed it to Alzheimer's disease and recommended that he get a referral to a neurologist to discuss treatment options. This doctor said, I conveniently saw this patient in the later afternoon when the symptoms typically arose. I walked into the room and immediately knew that a sleep study rather than a neurology referral was the better initial course of action. He appeared slumped over in his wheelchair, sound asleep. I had seen this many times before, in particular with patients with Down syndrome. As I suspected, he in fact had severe obstructive sleep apnea, and his symptoms ultimately improved with BiPAP therapy. So this is where, like Celeste was talking about earlier, with the low muscle tone affecting breathing and speech and everything else that can be associated with Down syndrome. So as health practitioners, we strive to serve without bias. One of our best tools to do so is recognizing that unconscious bias can occur despite our best intentions. By practicing self-awareness, we are equipped to recognize and address it if it occurs. Research supports a method known as SPACE 2. So this is the word space with the number 2 behind it. As you can see, S stands for slowing down. Stress, fatigue, and time limits create openings for bias. P stands for perspective taking, which is putting yourself in their shoes. Research shows that this is easy to do with groups we can relate to, but it is equally possible with unfamiliar groups when applied with intention and effort. A stands for ask yourself. Self-reflection with questions like those here help us become aware of personal assumptions and better relate to this group. C stands for cultural intelligence, which includes an understanding that culture and environment impact intention and behavior on both sides. The first T stands for exemplars, identifying examples in our personal or work or in the media of individuals with IDD who counter common stereotypes can help us train our own minds to focus on positive traits rather than the stigma or stereotype that we may have encountered. The second E stands for expand, which encourages seeking firsthand experiences, engaging members of the group as individuals.
We invite you to participate in the Space 2 exemplar activity. It's really quick and simple. Just think of an individual in your life who has IDD, or watch the video of Special Olympian Amanda. The link can be found in the video description below. And then write a short bio or list of the strengths and positive traits that you admire in them. So go ahead and pause the video now and come back when you're done.
Examples of potential impact of unconscious bias include a depreciation of quality and of life and ability. Although people with IDD have higher rates of unique or complex health concerns, many maintain fulfilling lives with school, work, family, friends, and community. A different quality of life does not equal a lesser quality of life. We all have the ability to define what a good quality of life means, and that definition is likely to be a little different for each of us. So caution is warranted in applying our own definition of what is fulfilling for someone else. In addition to recognizing their ability to define their own quality of life, It's important to recognize their ability to engage as members of society and engage as patients in discussing their own care and making medical decisions. Tools like the one we have linked here in the training and the slides um, can help patients and practitioners set expectations for their visits and identify what supports are needed. So you can see this is from the ARC, and it provides some guidance and some spaces to write down ahead of time what someone you might be supporting may wish or expect for their care. By increasing understanding of the community and improving personal awareness, practitioners become better equipped to provide person-centered equitable care where the individual and their community are celebrated for their experience. These relationships are based on supportive communication where our words match our actions and we spend more time listening. It's built on empathy where we care about what they want for their lives as much as what we know is needed for their health. So like Celeste mentioned earlier, the concept of what is important to and what is important for, and finding that balance of honoring what is important to a person while providing the supports needed to do that in a safe and way that supports their health and well-being. It means supporting them and being an active voice in their own care and doing the work and research to understand their health needs. Approaching care from this model leads to more positive health outcomes, stronger, meaningful relationships, and patient empowerment.
Thank you, Candace. So as we've mentioned, communication is essential to building positive and strong patient relationships and providing equitable care. So some of the skills that we're going to talk about moving forward seem really obvious, but it's important to always remind ourselves of them and continue to practice them. And they can be useful in not only patient relationships, but in any interaction. So we would want to start by highlighting some things that may occur during emergency or crisis situations. So individuals with IDD are more likely to be overwhelmed by emergency situations, leading to them being overwhelmed, upset, trying to get away from the situation. This can be physically trying to flee. It may also look like them going back to what Celeste said with like some of that people-pleasing behavior, saying what they think you want to hear to kind of try to rush this situation and finish and get out of there. In addition, they may have difficulty describing facts of a situation. So for example, if there were to be an accident or something like that, they may have a hard time telling you what happened. And then reporting health or medical issues, especially medical history, that may be pertinent to providing care in that situation. So just being aware of that is really important. And like we said before too, they have a higher rate of being diagnosed with PTSD, and just keeping that in mind and trying to be understanding of that in these situations is really important. So what can we do to help better communicate? The first thing is to create a supportive environment. And a huge part of that is allowing for additional time. We understand that time is a priceless commodity, especially during care visits, but investments early on can build foundations needed to support future visits and save time early on and create better care outcomes. Offering assistance, so ask them what you can do to make the space feel safe is really important. If you don't know what they need in an interaction, always ask, never assume. It's better to ask than assume in every situation. If the visit is causing stress, try engaging them in distractions. It's In office settings, you're less likely to have problems with this because you're able to have more secluded, quiet spaces. But for example, if you're in an emergency room or things like that, they can be very hectic spaces. So whatever you can do to kind of get them in a safe space is really important. If you can't remove them from a stressful situation, giving them distractions of interactions. So talk to them about things that excite them. That not only does this help with a distraction, but it can also help you better understand your patient. Another thing you can do is ask the person to help you. As we talked about, they love to be included. So if you can give them a task that they can focus on, that can be really helpful for creating a positive environment. And then maintain positivity. You have the power to set the tone of this interaction. So even if something happens that leads to an escalation in the scenario, as long as you remain calm, you're better equipped to help them return to that state as well. So once you have a supportive environment, it becomes easier to build rapport with the individual. And rapport starts with understanding them as a person. What is important to them? What are their concerns? And how do they want to engage moving forward? How do they want to communicate? How do they want to be a part of the conversation? And it's important to ask and figure that out. Also address the individual. It can be really easy, especially for those who may be coming in with a caregiver. It can be natural to end up talking and focusing on the caregiver, but it's very, very important that you are including the person supported or the individual with IDD. Talk to them and engage them, and put yourself at their eye level, but respect their comfort level. So engage them, but if they are distracted or don't want to look at you, let them set those boundaries. With that, validate their feelings. Let them know that they're heard and that it's okay to feel and act how they're feeling and acting. But it's also okay for you to set boundaries as well. Put limits on inappropriate behaviors. For example, if someone starts hitting the wall or something like that, that's it's okay to say that that's not okay, but then be prepared to offer alternatives. I always recommend fidgets are wonderful things. I use them myself all the time. They're great distractions, and great things to help you focus as well. So give them a fidget, something to do with their hands, an alternate positive behavior that they can engage in. So once communication lines are built, focus on communicating for understanding. What this looks like is maybe trying to slow down, avoiding raising your voice, using concrete language. So we kind of talked about this earlier, but being specific and clear is really, really important. So instead of just saying, get ready, you might say, I need you to put your coat on. And then the next step might be, I need you to go wait by the car. So very clear instructions that are broken down into simple, completable steps. Avoiding jargon, this is really important for anyone. Oftentimes, especially in health, we can have very, very complicated terms. So making sure that we're explaining that in a way that people are able to understand. Being prepared to repeat ourselves as needed. It might take some time for them to process the information. So it's okay if you need to wait or if you need to repeat yourself. And then check for understanding and then wait for those responses. So avoiding yes or no questions is kind of important. This is another area where you might end up having answers given that they think you want to hear rather than are actually true. So if you just say, do you understand what the instructions I just gave you? They might say yes and not really understand. So having questions where they are saying back to you what they need to be doing as part of their care plan moving forward. And then active listenings. As we discussed earlier, some individuals with IDDs have speech barriers or speech impediments that can make it more difficult for you as a provider to understand the feedback that they're giving you or the responses. And so using active listening and also saying back to them, okay, this is what I heard you say, was I right? Did I understand you correctly? Is really important to make sure that everyone is on the same page moving forward. And then adapting communication, as we mentioned, a lot of people, especially the individuals with mild diagnoses, are going to be able to communicate verbally. But there may be some that are on the more severe end of the diagnosis that have more limited language ability, maybe nonverbal or use other communication manners. And it's important to be able to adapt and still include them in the conversation. So asking the person to show you to model when they're answering, using pictures or symbols to highlight the things that you're saying, model on yourself, use actions to show them what you mean. Um, these are an example of great communication boards available out there that we'll have a link to in our description below that you can use as a point of reference. I also want to point out that many of these individuals have learned some sign language. So even bringing in a sign language interpreter can be helpful in some scenarios.
In a playlist with this webinar are 3 example videos highlighting the communication skills that we have just discussed. We invite you to check them out in your own time.
So with strong lines of communication, it becomes easier to identify those who will be involved in acquiring input and consent for care decisions. So as we've said, many people are capable of making their own decisions. They are their own guardians and should be allowed to make those decisions and do so. Um, there will be some who need additional support. They may have supported decision makers with them to help make those decisions, or medical proxies or powers of attorney to make those decisions for them. But no matter what avenue of care or what group of people are involved, in the care process, it is important that care teams work together to help everyone there understand the treatment plans moving forward and support them in being a part of that process. So our training is designed to serve as a foundation for improving health equity knowledge and care, but we are not the end of the road. We highly encourage you to continue learning and engaging with this community and this topic moving forward. There are a variety of ways that you can do that. For example, there are online websites with trainings and additional information that you can look at where you can delve deeper into the topics that we brought up today. In addition, there are many local organizations that you can reach out to, such as Envision, Special Olympics, ARC, and ECHO. Many of these have additional trainings that you can seek out or volunteer opportunities. When we brought up space too, one of the E's, that second E, expand, encourage you to seek firsthand experiences. So this is a really great opportunity to do that, reaching out to one of these local organizations and volunteering with them, just spending more time with this community and getting to know them and their needs and the amazing individuals that they are. So some of the ways that Envision can assist moving forward is identifying. If you need help identifying someone, if they are part of the program, helping to communicate or interpret if you have difficulty understanding the person, we can offer assistance with things like that. Providing information regarding a person's ability or history, but never hesitate to contact us if you think we can help. If we do not have the tools or resources, we will help find who does and work together to help provide the best care possible. So this is ways to contact Envision. Website is envisionco.org, and here are phone numbers if you would like to reach out. We want to give a shout out to Northeast Health Partners who provided the grant funding for this project. Thank you for being a part of this and for supporting us. Thank you for joining us for our training on promoting health equity for individuals with intellectual and developmental disabilities.
Before you leave, we do ask that you complete our post survey. Just like before, health providers and other health staff, your QR code will be on the left. For health students, your QR code is on the right, and the links will also be in the video description below. Thank you and have a great day.